Hello, everyone. I'm Alan Ho. I'm a retina specialist at Wills Eye Hospital in Philadelphia. Thank you for joining us here. Today, I would like to speak about a real-world study highlighting our need to improve early diagnosis of wet AMD, highlighting some of the results from the AAO IRIS registry trial that we reported on and published this year, and also reporting on some of the technologies that may be able to help us achieve earlier diagnosis with at-home monitoring. We did a real-world analysis from the IRIS registry confirming that the best results with anti-VEGF injections in patients with new onset of wet AMD is obtained when we catch the patients earlier. This is not a novel concept. If you look at the graph here, the CAT study had established that if you start with good vision, you end with good vision. This is actually established in multiple clinical trials. Our study confirmed that concept of essentially swimming lanes. That is, if you start with better vision, you stay with better vision over 1 and 2 years. And if you start with worse vision, using current anti-VEGF therapy in the real world as derived from the IRIS registry, you stay with essentially in that swimming lane. If you want to swim fast, you have to start fast. And that's the idea of catching the disease earlier. Only about 34% of eyes in the IRIS registry, and we looked at a lot of eyes, 162,902 eyes of 153,141 patients over the span of 4 years that had new onset wet AMD. Only 34% of those patients had visual acuity at baseline, initiation of treatment of 20/40 or better. Think about that. Only a third started in that fast swimming lane. Furthermore, in this era of COVID, more recently, we know that there's a delay in presentation. We looked at the Vestrum database and showed a statistically significant decrease in presenting vision last year to this year. And so there are multiple reasons for trying to detect wet AMD earlier. The IRIS registry, the Vestrum databases show that patients present late and even later when there are circumstances like a pandemic. If you start treatment at 20/80, for example, you on average end up with visual acuity at 20/80, but if you start at 20/40 or better, you end up at 1 and 2 years with better vision. One of the methods to monitor patients with at-risk, dry, intermediate AMD is the standard Amsler grid. There are other technologies, however. We counsel our patients to monitor their vision not only with an Amsler grid, but day-to-day by cross-covering their eyes to check each eye individually. Sometimes there's a delay in presentation because one of the eyes will develop neovascularization and loss of vision, and the patient doesn't know it because the other eye is doing well. The Amsler grid can help. This is the time-tested piece of paper that looks like a graph paper. But the other method that has been FDA approved now for years is the No-Tal 4C Home. This digital home monitoring system is very important in the early detection of wet AMD. In fact, in the ARIDS 2 study, subset study using the 4C Home, that study was stopped early by the Data and Safety Monitoring Committee because those patients that were monitored were doing better than those that weren't. 94% of patients in that randomized trial had early detection at 20/40 or better. Our study reported on the real-world use of No-Tal 4C Home, and although the IRIS registry shows that only 34% of subjects are 20/40 or better in the cohort that we explored, in the real-world No-Tal 4C Home, 83% of the subjects were at 20/40 or better. This is much more comparable to the data that were derived from the ARIDS 2 home study. arguing for implementation of no-tau 4C home for those patients that are at risk. Consider the patient with bilateral at-risk dry AMD, 80-year-old who during the pandemic doesn't want to come in to the office for fear of their general health. The no-tau 4C home offers them a good way for remote digital home monitoring. So how does it work? It looks like it's a piece of hardware, and it looks like a microscope that sits on the table, and the patients check each eye individually, and the program, which is cloud-based, digital, AI-enabled, tests each eye with a series of lights, string of lights, and there's a little blip in the sequence of the line of lights, and it's like a video game. Patients who do this, they're encouraged to do it maybe every other day or at least once a week, monitor the integrity of their central vision, and the program compares their responses on that day to previous responses. And if there's a change, that's signaled to the AI portion of the program. The patient is alerted of a potential at-risk CNV event, and the doctor's practice. We ask that in our practice that the patient and our practice is notified, and the patient is asked to schedule to come in for a potential event to be assessed clinically with examination and OCT. It is a digital technology, so there are, I'd say, some barriers to adoption. If a patient doesn't have an email address, doesn't have a smartphone, those are patients that I don't really discuss this with because I think the digital barriers may be too much for them to understand. But if an 80-year-old patient, as many do, has an email address and a smartphone, I tell them that I'll notify the company. They will handle the communications with the patient, instruct the patient, mail the unit to the patient, and go over testing and baseline testing to see if it works for that particular patient. If it doesn't work, the unit is simply returned. So the patient has to have some digital facility to use this. Patients will describe, Dr. Ho, the testing goes so fast, it's like a very fast video game, and they get a little bit of anxiety sometimes initially using it, and I tell them that fast nature, it's kind of like what you imagine a visual field is when lights are popping up all around, is by intention and is the method by which changes are determined between one point in time and other points in time. The other nice aspect about this is it's covered by Medicare in the United States, so there is insurance coverage for this. Some patients have coverage by secondary payers with a small monthly copay. Some plans don't cover this, but in the U.S. for the seniors, Medicare coverage is essential, since many of our patients that have at-risk AMD have Medicare insurance. We mentioned the timeliness of this particular technology in the pandemic when we're trying to do more remote home screening. We talked about the need for earlier detection. I gave you some information that 83% of the patients using 4C home in the real world were at 20/40 or better, as opposed to the IRIS registry where only 34% were 20/40 or better. So I think it makes a compelling argument. It does take a little time to discuss this with the patient. There's a video brochure that we have patients look at in the office. And I think it's a nice way to personalize care and provide a higher standard of care for patients with macular degeneration, especially those that are comfortable with digital technology. So I hope you find this information useful. It certainly was very interesting to me and very reassuring to know that using this digital at-home monitoring system performed comparably to the ARIDS 2 home study that established its FDA approval. Thank you for your time. I appreciate it very much.